some of the work that we have been doing over the last 4 months here, 5 months in fact, on one of the projects that I was involved with. So it's a pleasure to talk and share some of the data. Ocular grafts versus host disease is what my topic is. Hematopoietic stem cell transplantation has come a long way from being an experimental procedure to more or less the standard of care for hematological and lymphatic malignancies. The success these days is due to multifactorial, because we have better induction regimes, we have better conditioning regimes, better way of harvesting the stem cells, traditionally used to do from bone marrow, but now from peripheral blood or cord blood. So these all have resulted in much more higher success rate for successful transplantation. But again, coming to that, the major cause for morbidity in these transplant survivors is due to the graft versus host disease, which typically starts as an acute or a chronic phenomenon. The traditional classification has resulted in, has been, depending on when it happened, within 100 days or after 100 days, and has been classified as acute versus chronic. The more recent NIH classification takes into account more on the clinical features rather than on the time frame, and they also describe an overlap syndrome. So the acute graft versus host disease is more or less acute inflammation of the skin, of the GI tract or liver, and this typically usually is within the first 3 months. The chronic is more of a pleomorphic, more complex disease. It's a chronic inflammation resulting in the skin, GI tract, liver, lung, and eye is also involved. That also can be involved in acute phase as well. The actual incidence of graft versus host disease is close to around 40% acute and around 30 to 70% depending on which series you look for the chronic variety. Ocular graft versus host disease, where the ocular features are around 60 to 90% of the chronic GVHD patients. Classically described as more or less as a dry eye syndrome, it can also be causing other sequelae, more like chronic inflammation and cicatricial changes. And posterior segment anomalies, even though less, some around 10%, it can also involve the posterior segment. These all lead to a poor quality of life and even can result in severe vision loss. It's a T-cell mediated process, a classic 3-step immune attack on the target organ. The host tissue damage from the conditioning regime are picked up by the antigen-presenting cells, APC activated, cytokine proliferation, co-stimulatory molecule upregulation, and then resulting in target cell attack by the donor lymphocytes. The chronic variety is more of like a Th2 response where there's more fibrotic process involved with IL-4, IL-10, and TGF-beta all resulting in a chronic fibrotic process. The management, more or less acute and chronic, is pretty much based on inhibiting the T-cell activation. So calcineurin inhibitors, CellCept, tacrolimus, and cyclosporin, along with steroids, are pretty much the mainstay of treatment. The ocular GVHD has a limited role for the role of systemic immunosuppressives, more reliable on topical cyclosporin and basically ancillary treatment with plugs, cautery to stabilize the ocular surface. So the purpose of this study was to look at our Wills-Eye experience over the last 10, 12 years on the clinical features and the management and the diseases and the outcome of patients with ocular GVHD. So it was a retrospective chart review of patients with ocular GVHD who has been referred from outside, specifically with the ocular complaints to the eye clinic. We extracted the demographic features, baseline disease, transplantation status, and clinical features and survival data. GVHD was diagnosed based on the NIH classification, as I said earlier, and the dry eye was classified into mild, moderate, severe based on the dry eye workshop criteria. So there were 38 patients from around 2000 to 2012. Some of them were complete obsolescence patients way back in 90s. with a mean age of 50 years and a mean follow-up of 22 months. So looking at the baseline characteristics, there were 26 males and 12 females. The commonest indication was acute AML. 30% of the patients' transplantation was done for the AML. A variety of other indications also were present. Looking at the type of transplant, since most of our patients were in the earlier part of this decade and the late 90s, 25 of the patients had received bone marrow transplantation, and 13 had a stem cell from the peripheral blood, which all matched allogenic. 4 patients had more than one transplant because of poor uptake of the first transplant. Majority of the patients in our series was chronic GVHD, with 2 of them with a little overlap symptoms. The time to GVHD that usually has been reported to anywhere between 3 to 6 months, and in our series we found that it was around 9.5 months. The time to ocular complaints or ocular presentation with symptoms was around 34 months. What has been reported in literature is around 6 to 12 months. So in our series, patients presented much more later. We had a follow-up of around 22 months, ranging from 1 to 300. Looking at the systemic features of our cohort of patients, majority of them had skin features, chronic dermatitis, depigmentation, and the other commonest features was oral lesions and liver function changes. The dry eye symptoms, 27 out of 38 patients had a pretty severe dry eye at the time of presentation, which is not surprising when you consider that the patients presented around 34 months since they had GVHD. So it's not surprising that most of our patients had 70% had a severe dry eye. Coming to the clinical features, meibomian gland dysfunction has been reported to around 45 to 50% in the literature. It was very hard to look at that because this was the first time we had seen these patients. Only 8% had severe blepharitis. So it was very hard to see whether they had a coincidence. Everybody above the age of 40 or 50 has some amount of meibomian gland dysfunction. So it was very hard to say whether it was related to GVHD or they had a previous meibomian gland disease. Coming back to other features, one of the 35 to 36% of people had subepithelial fibrosis, and almost 95% had a punctate keratopathy, and 18% has filamentary keratitis. There were corneal ulcers in 7 patients. 4 of them was bacterial, 1 was a fungal, and 2 was neurotrophic. 5 patients perforated, and 8 patients had some limbal stem cell deficiency. We had only 2 patients with the posterior segment involvement, uveitis, and the same patient had uveitis and CME. The other one had a vitreous hemorrhage, but he also had radiation retinopathy, so probably not related to GVHD per se. We looked at the treatments that they had received in the past. So majority, as I said, had been treated with the prednisolone or a T-cell calcineurin inhibitor. So 70% received steroids and 30% close to had either CellCept or tacrolimus. We also look at the number of agents that had been used in the past. These are not at the time of presentation, but has been used in the past. Almost 60% had required at least 2 immunosuppressives, and 20% 3 or 4 agents in the past. Coming to the ocular management, pretty much the mainstay, your tears, restasis pretty much has been the mainstay in all the patients. Punctal plugs and cautery were almost in 65% of patients had a punctal plug, or cautery in 25%. Prose lens was used in around 5 patients, and in another 8 patients we had referred for Prose lens. Patient did not go for it because of other issues. 2 patients underwent PK, and one patient underwent a keratoprosthesis. Looking at the outcome of a treatment with all the modalities, 63% improved, 24 patients improved out of the 38, 8% worsened, 6 patients remained symptomatically the same. One patient developed the conjunctival carcinoma in situ, but then he was one on the multiple, more than 4 immunosuppressive regimes, so could be a immune related as well. 6 patients died. 4 of the 6 was associated, had a corneal perforation, reflecting a little bit more severe corneal problem or ocular GVHD. The mean time to death after the corneal ulceration was around 7.5 months, and this has been noted in other publications as well. So to summarize, it's a chronic inflammatory disease, just not dry eye, much more than that, and it can lead to severe complications as well. Few things I just wanted to highlight. One is that the mean time to seeing the patients was around 34 months, which was longer than what has been reported in literature. And consequently, more than 70% has severe dry eyes that made the management of these patients much more difficult. One of the problems is that patients with acute GVHD, they are more sick and probably hospitalized, and you tend to see them less in an outpatient setting. Second point that I want to raise was these patients need to be possibly treated with some topical cyclosporin or something very early in the disease, because it's a T-cell mediated, because otherwise they will have chronic inflammation and lacrimal gland atrophy eventually, so resulting in much more severe dry eye and other complications which are much more tougher to manage down the line. Again, 7 patients had corneal ulceration out of 38. That's pretty huge for a dry eye cohort, and 5 of them had perforation and 4 of them had died at the end of the study. Thank you, and I'll be happy to answer any questions.